Welcome, everybody, to today's Fireside Chat. For those of you that don't know me, I'm Rita McGrath, professor at Columbia Business School, among other things, and I am so thrilled to have Glen de Vries here as my guest today. I had the great honor of chatting with some folks from his company during a leadership event that they had. And so that's how I got to learn about Medidata. I got the book and the consequence of doing that, and like, whoa, this is interesting stuff. So Glen is the co-CEO, co-founder of a 22-year-old company, Medidata. We'll talk about Medidata just in a minute, which just, I guess, 2 years ago now was acquired by Dassault Systems. So one of the largest healthcare acquisitions, and certainly the largest in the medical data space. A couple of reminders: this is being recorded, so do not say anything you do not want your mother, ex, or anybody else to be
make
able
a note of that.
Yes, make a note of that. Nobody who's in legal risk should be just saying anything. And we will be monitoring the chat. I don't generally do raise hand stuff just because I don't know everybody that's logged on, but we will monitor the chat. And if we don't get to your questions today, we follow up with answering them afterwards. So that's briefly how we do things here. And I thought, Glen, just welcome. And thank you so much for taking an hour out of your day and joining us.
Thanks for having me.
Love the background.
My home, it's where I live. So I'm right by NYU. I was born like 1.5 kilometers over there, so I haven't actually gotten that far.
In the virtual time, right? You could be anywhere. It could
Fair
be
enough.
Anywhere.
Fair enough.
So let's just start. I want to start out with something that was in your book, which I thought was interesting. And then I'd like to get into the journey of how you got there. And one of the most interesting lines in the book to me was, "Our health follows paths." And that up to now, we really haven't had the tools to make much sense out of what those paths mean. And of course, paths have path dependency. That's the word. And they have forks and they have twists and turns. And if we can better understand that path, there's a lot of power that brings to us. So I thought maybe start off with what that sentence means to you.
Okay. So nobody's asked me specifically about that. And I'm going to tell you something that I don't think I've ever talked about in the context of the book, or even that often, but it's related to a lot of the kind of visuals in the book. And I like being kind of a geometric visual thinker.
Yeah,
and actually, so if you asked me, so the company's 22 years old. About 26 years ago, if you asked me what I'd be doing now, I would have told you I'd be teaching biology at a university somewhere. And I wound up very quickly in oncology, but actually one of my first loves as an undergraduate was virology. And there was an article that was in, I believe it was in Science. It was either in Science or Nature. This is a quarter of a century ago. And it was plotting viral genomes and the mutations in them in 3D space. And actually, it's probably interesting for people to think about from a SARS-CoV-2 COVID-19 perspective. But basically, the idea was, if you take the reference sequence of a virus, and this was easier to do back then because it was easier to sequence these short genomes than what we can do today. But you start with kind of the reference sequence as the origin, and then you plot every mutation as a shift in three-dimensional space. And what you wind up with in the construct that the people who wrote this paper created is basically something that looks like an amoeba. It looks like a single-cell organism. And the really cool thing about the article was that if you introduce an outside force, then all of a sudden, just like a cell would, it will, like, the shape of the genome will extend like a little pseudopod towards something or away from something. And I honestly have no idea what happened with this research, but what the idea was, you could plot the arc of this not single organism, but this population's existence in something that was easily metaphorically a kind of single organism construct. And you could use that as a way to understand what was happening to it. I think that is the first time I got into this idea of representing biology in a n-dimensional mathematical construct. And as my career progressed, and as I thought about different kinds of cancer, and as I thought about different types of research and how that should affect them, I don't think I ever got away from this 3D space. And that's really where this idea of, we are right now, like that reference genome for that virus, at a point of time, at a point in a health space, and any choices that are made, the burger or the salad, the shift from a first line to a second line therapy, the decision not to get treated, a vaccination is altering the path that the point that is our now is going to be on. And that theme really is in the book over and over again.
Oh, it's fascinating. It's absolutely fascinating. And what you do throughout the book is really talk about that notion of people trying to create their own the book's called The Patient Equation. You create their own equation for what the way to have it. So let's go back to where you sort of got started with this, because there's some wonderful stories about, being very frustrated at just like before you could do your work, you had to get the data. And I think so many things in life have that quality to them. Like I'm working on building some software, and before you can build any software, you have to build the security thing, right? Before you can, become a fashion designer, you have to study, stitching. I mean, there's all this. Right. And you talk about being really frustrated with what that was at the time. And then the phrase you use is coding your way out.
Yeah. So I was always and I say this term proudly, I was always a computer nerd. Like I grew up in a time when you probably didn't have a computer for a while at home. You had to go use the Tandy TRS-80 in your school computer lab. Ultimately, when I was kind of in high school, and like towards the end of grade schools, when people started having computers at home, and it was like, oh, you really wanted to go over to the person's house after school who had the coolest computer, because you could code on that and play games and tear it apart and do all kinds of interesting things. And so at every point in my life, honestly, still today, it's like, oh, is this something that I have an excuse to write a program for, write some code for? And it's usually for fun, but it's also a professional reaction to things. And it started back when I was at Columbia, and I literally had this project, which was ultimately a precursor. And I don't mean this in a way where I want any credit for it, but it was kind of the way people think about liquid biopsies today. So we were taking the blood from prostate cancer patients and trying to figure out what the best course of therapy was for them by performing a molecular assay on their blood. Basically, could I not detect very specific mutations in their cancer and try to stage it or categorize it that way, but like literally, are there prostate cells in this guy's blood? So it's a guy. And if there are, that means something, because either that patient has a metastasis or has the potential for that to happen at any moment. So if we take out their prostate, that might not be curative. So long story short, I'm doing this molecular assay. I'm literally doing the work. So I'm running around the hospital to get blood from patients, and I'm putting it in the freezer behind me, and I'm taking out tube after tube and spinning out all the cells and extracting the messenger RNA and running it through gels and taking pictures of the results and blah, blah, blah. And all of this is winding up in my lab notebook, which literally on its own is not interesting information unless you were trying to figure out how many times I could do this assay over and over again. I guess you could plot, Glen's performance in assay production. But to actually make the results of that at all interesting, right, to figure out if there was anything that was predictive about this, you had to match up the results of that assay to what we knew about the patient from other dimensions. Again, this goes all back to this thinking in like the n-dimensional space. So we knew what the patient's pathology report looked like. We knew what their blood chemistry looked like. If there was, probably anybody who works in prostate cancer, or hopefully you haven't, but it knows somebody knows what PSA is like. Can we look at their PSA? Can we look at all of their medical history and add this assay that we were doing at Columbia at the time? And once you add that assay, do you have any more predictive power? Well, predictive power for what? For what the outcome was when this patient had their surgery or whatever the modality was that they used for whatever intervention. And then, so I had to get data later about them in the future. Here I was in the lab bench, connected to nothing. So I was constantly on a quest to literally get sometimes to medical charts, like to figure out what physician at Columbia saw this patient and go over to their office and make sure I've got all the right people who, aren't going to kick me out because I'm looking through the chart and copying.
This is 94, 96 kind of time.
This, yeah, 94.
So 95. Right around there, just to put this in people's minds, because we all forget, right, that back then how you got on the internet was you had a modem and it went,
Yeah, we had an internet line in the back of our lab that went to a Windows 95 PC at one point after I had arrived. We all shared. And so I was like transcribing things from the charts. And then I had to go to different buildings to get on different hospital systems to get pathology reports and to get test results and surgical reports. And by the way, it's 25 years later, and that still is like that. You still have to go to different systems and hospitals to get this information and consolidate it all. And it was just super frustrating and boring and slow. And it was just like why can I not code my way out of this problem? This is all information that's connected to computers. I love computers. There's this thing called the internet. And like, apparently I can go buy a book. And I would say to people, like, you're talking about, like, remember what time it was? I always use, like, the only thing you could buy on Amazon at this point in the time frame of humanity was a book. That was all. They were just books.
That was July of 1999.
Before that, right? And so it just, if we can do that online, if people logged on, I know how quickly people came into the room after you opened it. Like we were joking about, like, we can put people on the moon, but we can't, stop robocalls. Like we can buy a book online. Why am I walking across the street to consolidate data and doing it all by hand? And that was really the beginning of Medidata.
Mm-hmm. So what did you do then? Because, you've talked about, you started off with the problem, and I've had wonderful entrepreneurs that I've had conversations with, like Jim McKelvey, who started Square, and his origin story was he's a glass blower and missed out on a sale because he couldn't take American Express. And he's like, the phone does everything else. Why can't it take credit cards? And so I find so often these really clever entrepreneurial businesses get started with that kind of scenario, right? Why can't you do that?
So I in no way mean this to sound negative about somebody who kind of grew up as a technologist and found an interesting problem to solve because they looked at the world with technology colored vision. Because actually there are a lot of really amazing things that get started by people who come in that path. But there's a very different path that Square and Medidata came from, which is somebody who's doing something that's not technology related, but realizes technology is a potential way to solve that. And that was really the origin of Medidata, was coming out of that kind of problem space. And as we began to solve for this, and now treating a couple of decades as a very, very flip way from a time horizon, but we started to solve certain problems, and we realized by solving them, more and more of the problems that were medically interesting, that were scientifically interesting, opened up to solutions where technology could help, where connecting data could help, where connecting different people who hadn't been connected before could help. And the first decade of the company was spent entirely connecting, for example, professionals, or at least I'll use that term in terms of clinical trials. Sometimes the professional might be a nurse or a physician who was working in a hospital. And if you said, what's your job? They would say, I'm a nurse or I'm a physician. But from a clinical trial perspective, they were getting paid to do the trial. But the professionals in a clinical trial are the minority. And they're not even an important minority. The only real important constituency is the patients who we are trying to serve, who we're trying to determine, is this new therapy or this new diagnostic better than what exists today? And so we spent a decade connecting the professionals, because back then there weren't enough computers everywhere to connect all the people. But then all of a sudden, like, everybody got a phone, and it's funny. What we call a phone today is actually a computer, right? It's the word has changed meaning. But all of a sudden we had these computers in everybody's pocket. And then 10 years after we started, same mission, same ideas, but we started to connect the people. And that's, I think, a good example of what I mean by, like, new opportunities open up once we started that initial connection, created that floor, and then you constantly find new kind of rungs of that ladder you can climb. And again, we're an N of one, but I do think that's probably something that successful entrepreneurial companies that can continue to grow and do interesting things, they find that way to climb that ladder as they've solved these real world problems.
Yeah, that's a pattern that we see, and that's what actually gives you competitive protection too.
Yeah, absolutely.
Like Jim McKelvey will talk about how they fended off Amazon just because they were so enmeshed in solving these very specific problems that nobody could really touch them. But your start as a business person wasn't exactly, the business plan with the VC backing and the spreadsheet, with your 10-year forecast.
that came thanks to my 22-year now office mate, Tariq Sharif. And there was a guy who I worked with at Columbia, and he looked at me and Eddie Kikuchi, the other Columbia-based Medidata founder. We were in science and medicine and loved computers. And this guy who was a friend and mentor to us was just like, you guys can't do this. Like, you don't know anything about money or businesses or business plans. And he introduced
us. Gross or net revenue? Was that gross or net revenue?
Oh, you know that story. Yeah, it's like, this is how you know how bad I was at business when like we had $1 million and $1 million that we had made in a particular year. And I was describing that to somebody. And I was saying, oh, yeah, we made $1 million last year. And they said, is that gross or net? And I said, total.
That's wonderful.
So thankfully I met Tariq, and thankfully he knew what gross and net meant amongst a huge amount of other things. And really interestingly, he had done a bunch of investing in technology companies, was a very inquisitive domain. Was very interested in the domains that the technology companies were working in, and very inquisitive about their very specific technology strategies. So he was very good at asking questions about things like that, but had also made an investment in what was called Quintiles at the time, which would ultimately become part of IQVIA when it was a private company. So he knew a bunch about the clinical research world as well. And between that and just being a real, the same way I was, I would still wake up and think about, biology and science. He wakes up and thinks about, business and investments and markets. And we really were able to, I think, complement each other in a great way, which is obviously continued to today. But yeah, that all of my business knowledge is from the mean streets of entrepreneurship, I guess, through IPOs and sales and things.
That's wonderful. That's absolutely brilliant. So in the book, you start off with talking about not even getting into the tech, but this patient who kept all these records, really tracked his own health in a way that I think is very interesting. That it began, I think the way you tell it anyway, it gave you some insights into, if we could connect what he ate with where he was, with his presenting situations, with what his sleep was like, and that very few patients did that in those days.
Yeah, and this is what I think really pulled out, I think, in the right way, right? This idea of path and what path are you on, and Jack, who the first story is about, who sadly has passed away, but he definitely kept himself alive longer than he would have been alive. Because he was so proactive about tracking his path. He literally tracked it in an Excel spreadsheet and looked at his kind of key biomarkers in this proxy, pretend high is good and low is bad. And he would watch what happened when he took different medicines, when he went on or off different clinical trials, and really created remember I was talking about that amoeba in the original example that was a mathematical construct, but you could see how it could react to things. He was watching his own biology that way. He was watching at a higher level than any investigator working in a single clinical trial or a specialist that he went to see for some period of time. He was looking at the evolution of his biology and his disease in a way that I think allowed him to make really good informed choices. Interestingly, way back in those Columbia days, the kid who was running around the hospital trying to connect all the sources of data and write them in his lab notebook was also running around the hospital looking for patients to consent and get blood from to bring them into the clinical trial. And even before Jack, there was a guy I met who was an engineer who had prostate cancer. And in his wallet, he kept a piece of an engineering pad for people who, I love those. It's like these little green pieces of paper with a graph paper printed on the back side of it. So there's a very subtle graph on it. And he had a piece of engineering paper in his wallet with dates and his PSA scores. And I think he was the first person I ever met who I saw tracking their health in that way. And it was literally the PSA when he first heard from his internist that he should go see somebody about something wrong with his prostate, all the way through to his pre-surgery PSA that had happened from a blood test days before I got him into the study. And so when you see people doing that, and then going back to Jack Whalen, when you see people getting benefit from that, it started to me thinking about, is this a useful construct? Interestingly, and I'm wrong about so many things, but sometimes I am right. Maybe it's just a little dumb luck. But I now am in a lot of conversations with people who are in the top of their fields, and they're looking at how to create these paths because they want to do the same thing at scale. They want to be able to look at how did a patient, what was the journey, what was the path of that patient to the moment that they're trying to help them make a critical decision, a potentially a life and death decision about what therapy to use next. And they've realized that the short period of time that they see doesn't show you enough of the path to really understand the trajectory and where people came from. And again, in some cases, maybe it's not relevant, but it's certainly a key hypothesis in the book. If you had that information, you would be able to do a better job of predicting what is going to be successful in the future. And frankly, if you had that information, maybe you could leverage to help other patients who might be on similar paths make better decisions, not just at a given point in time, but at earlier points in time. And so that has driven certainly a lot of strategy for Medidata, now for Dassault Systems, but also just a lot of the things that kind of interested me outside of work too, from an intellectual or academic perspective.
Yeah, I totally see that. So in terms of how the company got started, the first few customers, because it's one thing to have this hypothesis, right, about if we could figure out paths, we could do better treatment. It's a completely different thing to get somebody to pay you to provide them with certain kinds of information. So how did you get the first few transactions going?
So the first few transactions had a $0 invoice related to them.
Okay.
They were
not hard to start a business like that.
It's great.
I know this from experience. Those businesses are really easy to start.
But remember, this was all like before the .com bubble burst, and we weren't like this. But I think that like the chic phrase back then was, "What's your burn rate?" which was related to how much money are you burning every day. Which, even though I don't have an MBA, seems like a terrible idea, like in any context. But
well, I have a point of view about what's happening with today's VC-backed companies. I mean, it's like, guys, didn't we learn? Like, I was around nothing. It was terrible in the early late 90s. It was terrible to be an entrepreneurship professor then, because your students would say things like, and you'd talk about conserving your capital and, get sales in before you incur expenses and keep expenses variable. And they'd look at you and they'd go, well, I've got a business model and $1 million from a VC. So what are you talking about?
Right. Yeah. So in this little sidebar, Tarek also can be wrong about stuff, but he was one of the people who, when all this was happening, was like, this is crazy. We need to think about things around conserving our capital and how do we make a profitable business and grow it. But back then, this was a crazy new idea. And we did go to some of our friends in academia, people who we knew through kind of our community. And we said, look, we've got this better way to do research. And that was really how we got our first clients. I will tell you from an entrepreneurial perspective, I'm going to go visit somebody who's retired now. It's going to be my first, like, as people are getting their vaccinations, like post-COVID trip. And I'm going to meet up with this guy who I've been to his kid's wedding. They all call me Uncle Glenn. I mean, I know his whole family. My parents know him, like he's really a member of my family. Well, when I first met him, he was after we're like trying to make money and get sales, he was a salesperson whose resume came over the transom from one of our early investors. And the first time I saw him, I was like, there is no way this used car salesman is going to sell our beautiful software for doing research. And I learned my first lesson in real enterprise sales from him, because he took myself and Tarek and Ed and kind of deconstructed who we were and got us separated and in one-on-one conversations and figured out how to triangulate a way for us to all come together and say, oh, we should hire Steve Hirschfeld. And we did. And I actually think the experience of seeing what good sales looked like in hiring our first real salesperson, who fast forward, I don't know how many $1 billion of Medidata software Steve sold under his purview in his career, but it was billions of dollars. You need to figure out how to make those sales happen. And certainly as a person, again, N of one, I could be wrong about so many people, but I think if you're one of these people who came out of a business, came out of a scientific problem, aren't a business person and you're starting a business, you by definition almost don't know how to sell what you figured out, and you really need people to guide you, help you, if not do it for you.
Mm-hmm. Oh, I totally agree. Part of the problem is when you're too close to it, like, and it's obvious to you. It's like I know some, because I'm at Columbia, so I know a lot of people who are borderline geniuses, if not actual geniuses, and they'll look at you when you sort of present something, and they're like, well, of course, like that's so completely like, why do I have to explain that to you? And yet, if you're going to sell something to someone, they kind of need to understand all the wheels that are turning in the back of your mind.
I'll tell you another embarrassing. It's like a gross versus net story. I'll tell you an embarrassing venture capital story. This is in front of people who eventually did invest in us. I didn't really understand how to get in front of people and present the business. I was talking about one of the decisions we made, which also turned out to be, in this case, a decent one, about how Medidata software worked. And instead of like laying everything out and kind of designing your clinical trial super bespoke and specifically, you would kind of put into Medidata, this is what I want to measure. This is how often I want to measure it. And it would kind of automatically create the system for you to collect that data. And this VC, he's a great guy. His name's Todd Petrie. He's at Milestone Venture Partners. I think they call themselves something else now, so I apologize if I've screwed up their current name. But it's like, so if this is such a good idea, like, why are you the only people like doing it this way? And my response was apparently because we thought about it. It's a terrible answer. It makes me seem like a total jerk. And there was no way substantive, but it's exactly what you're talking about. You're just too close to it. And you need people to help you figure out how to express yourself, whether it's to an investor, whether it's to a client, whether it's to an employee. Like you got to figure that stuff out. I still think I can always do better with those things, like every day. I don't think maybe ever figure that out perfectly.
Absolutely. So one of the things that you're justifiably proud of is the culture at Medidata, and one of the things many entrepreneurs that I work with will tell you is the culture. You had to create it, and it had to be there from the beginning. That was, it's part of a series of choices you make in that founding moment. So how did you think about that, or was it just a reflection of who you guys were, or did it become conscious later?
I think it's got to be a reflection of who we are to some degree, because if you're an N of one, but not actually being your true self is probably not that scalable thing to do in business. It came out of that. I think it became a virtuous cycle, because we wound up hiring people who worked the way we worked, liked the way we worked. We didn't have any walls in our office, so people who wanted to sit in a cubicle 11 million miles from other people and work in an isolated way, it just wasn't physically possible, right? So that happened. I do give credit actually to some of the stuff I experienced as a kid. My dad worked not in a particularly fancy way, but he actually did some training in addition to being a broker dealer at E.F. Hutton. He worked at this firm that went down in like Wall Street scandal, but I think it was stuff that everyone did at the time, and he certainly wasn't involved in any of that. But I remember my parents got divorced, and I would spend time with my mom or my dad. If I was with my dad, sometimes there was nowhere for me to go, and I would like go to his office and hang out there before I went home. And I realize that intellectually now, having grown up and spoken to him and talking to his friends about what kind of company he worked at, it was a place where you could be equally likely to find yourself next to a C-suite officer or somebody from the mailroom at the bar after work. And everybody just hung out and was friends. And told you, as a kid, was into computers. My dad had done some of the training programs as a trainer. I think is how he met this guy. And we were in the elevator. I think I was like off school and he had nothing to do with me. So he took me to the office, and I was going to sit in the corner and play with one of the it wasn't Bloomberg back in those days. It was a green screen and you needed to know all these commands and terminal. Anyway, and we ran into the chief information officer in the elevator who said, Alan's my dad. He's like, hey, Alan, who's this? And my dad introduced me and said, oh, Glenn, this guy like deals with all the computers at EF Hutton. And I was clearly starstruck. And the CIO took a colleague's, not a senior colleague's kid on a tour of their data centers that morning. And I'm sure if he had a meeting he had to go to, he wouldn't have done it. But it was like that kind of company where people were kind of cool to other people. And I remember looking at all the tapes and giant, probably 1 megabyte hard drives that were half a room. I'm sure that influenced me. Seeing a company like that, growing up with that kind of experience, I now cannot take that out of maybe part of how I think at least about Medidata. But look, Tarek and I, 22 years later, don't have a wall between our desks. He's more of the business thinker. I'm more of the science thinker. If you put me in front of an investor, I won't like completely fuck up that meeting. Like, is that okay to say on your if you put him in front of a chief science officer, he'll do fine. We can do that now, but it's because we didn't have that wall between our desks, and it's the way we like to work. And I think that set a lot of that Medidata culture.
That is so cool. That is so cool. Well, EF Hutton for a long time. I mean, this is one of the things that frustrates me when people tell business stories, because we all know it didn't end well.
Right.
But that didn't mean it wasn't awesome for a really long time before the sequence of events that meant it didn't end well were in place. And it's a bit like health. I mean, not to overstress the metaphor, but the fact that somebody had an adverse event at some point in their lives didn't mean that there wasn't a lot of great stuff happening before that. And then back to that sort of path, right?
Yeah. Yeah.
There's a lot we can learn from that.
There's a lot we can learn from that. And there's a lot that we can, there's a lot that we can learn when we look at something like EF Hutton and find like interesting aspects of their corporate culture. And there's a lot in health too that I think is like really actionable, right? I mean, you need to put things in context to really understand them. And, you don't want to throw away a huge amount of what is a positive, useful part of your health because of a particular adverse event or diagnosis. If anything, the path, you want to take advantage of that and use that to try to get yourself past whatever, ails you.
I love that.
Yeah.
I never thought of that analogy before. That is going to be cool. I will come back to that. Because, for example, for years I worked with Nokia. And there was a period in time where you could not move down the halls of Columbia Business School tripping over case studies about how awesome Nokia was. Or you could substitute General Electric or Dell or, insert star company of your choice. And then something happens, something goes wrong, they screw up or they have an unexpected setback. And all of a sudden everybody invalidates all that stuff, right? And we burn the case studies, we pretend they never happened, and they take them out of the catalog. And it's like, no, there was, you have to look at the entirety, I think.
Yeah, I always, just because I'm such a huge Apple fan, I don't really give credit to BlackBerry where it's due, but I just thinking of it as you said that, it was BlackBerry who changed the word phone into something that meant computer, not Apple, right? And maybe it was even Nokia, right? And people doing it earlier when they started to have screens and things, depending on how technical you want to get. But this idea that it's a thing where you get your email and manage your business, that wasn't the iPhone, right? Somebody else did that.
Oh, yeah. Nokia had that years before BlackBerry even had it. So here's a little known I hang out in Helsinki for a lot for my youth. And back in this would have been in the 90s, right around that time when I first joined Columbia, Nokia had a thing called the Communicator. And it looked a little like the Star Trek, beam me up Scotty thing. It had a sort of flip cover and it had all these buttons and things. But
I believe the word you're looking for is tricorder, but go on.
How did I know you would know that? How did I know you would know that? Anyway, so this thing was, the supercomputer in your pocket, and all the executives. I was working at the time with a company called Sonera, which was the local phone operator. But Nokia and Sonera were very much joined at the hip in terms of their affection for technology. And two things, and I do want to come back to the pandemic and the moment that we're in. But at the time, my host said, "Oh, Finland's the perfect place for the commercialization of internet communication technology." And I said, "Why is that?" And he said, "Because we're very shy." We don't like to talk to each other. So the fact that we could send messages backwards and forwards to each other was a wonderful thing.
They're like, can you imagine a world where we go to dinner and don't talk? It would be great.
Right? So I just thought that was a real interesting early warning of the use case we'd later be encountering.
That is interesting.
But yeah, I mean, they invented a lot of that stuff. BlackBerry gets a lot of credit. I mean, I think Apple really had sort of excelled was this bridging of with the human interface, right?
Yeah.
But the core use case was well demonstrated by the time they got into that act.
Absolutely. Yeah.
So back to the book for a sec. So you have this book. Clearly, you've been thinking about it a long time, and then along comes the pandemic, and you must have been looking at like the due date for the book on your calendar with relief, because finally you're going to disgorge this book, and that's one less thing on your list. And now you've got a pandemic thing, which is at the heart of what you're writing about. What do you do then?
It was even slightly more bizarre than that, because the book was like done, final proofs checked, and being printed. And
wow, I didn't know it was that far along.
And get a call from Wiley saying that Wiley's the publisher, the actual printing press company is closed because of COVID. And the book is like sitting, in sheets that need to be cut and bound. And so they're going to figure out what's going to happen. And then that company wound up going out of business, or I guess declaring that they were going out of business, or whatever it was. I wasn't involved in that stuff, but basically the answer was what was printed was never going to get bound. And it actually kind of turned into an opportunity. And so actually what you have is really like a second edition, even though no first edition came out. And they didn't want to, it was like, okay, we're not going to rewrite the whole book, but let's address what's happening, be disclosive about the fact that we don't know what's going to happen, but try to incorporate some of the stuff from the COVID-19 experience to date. This was in like the beginning of summer last year. So it was slightly terrifying writing about something in the middle of it, not really knowing what was going to happen, but we weren't completely wrong about everything, at least so far. And in an interesting way, it kind of tied a lot of stuff around technology together. And so I'm not even sure if it would have been as good a book if it didn't have the COVID stuff in it to kind of pull some of the things together at the end. And it is interesting to see that what's happening now in kind of healthcare and life sciences, a lot of the innovations that were started back in the pre-COVID days around connecting with patients directly and thinking about research projects in ways, just as an example, where you don't have to work in the context of an academic medical center all the time, these are things that in a good way, that genie's not going back in the bottle, because we all realize you can't always go to an academic medical center, even if you're lucky enough to live near one. Something could happen that means you can't get in there. And we're realizing that, maybe we spend too much time on Zoom, but it is nice and convenient to go talk to your friends in Helsinki or Tokyo on Zoom. And I will never look at a pandemic and say, oh, wasn't it good that happened? Clearly not. But it is leaving this, I think, indelible effect on, if I can go back to our path, on the path of what happens in healthcare from a technology perspective, and probably from an expectation perspective in terms of how everybody wants to interact with their care team. Oh yeah, and so there will be a silver lining, at least in that context, and I think that's why some of the stuff that came together in the book made a decent amount of sense.
It really does. So one of the phrases that just caught me in the book, the section's entitled "Putting a Spotlight on the Fragility of Our System," and I'll just read a section of it. It's not just COVID-19 patients we've had to worry about as the pandemic has unfolded. It's been everybody at every point in our healthcare system. Whether a patient is in a clinical trial or just trying to get a regular checkup, our health system is based on the physical co-location of a patient and a practitioner. It's a debilitating weakness. And I thought that was just, it kind of gave me chills when I read that, because I absolutely think that's a core to so much of what's wrong and so much of what's difficult, in getting healthcare treated.
It's Absolutely. And one of the things that I've really come to have also some optimism about, but it just is part of that debilitating weakness, is some of the problems that we have around access and equity of care. And I keep coming back to this article that is now a couple months old. It was in Nature Medicine. It was a letter about the distance that people live to a hospital, and it had maps of the world. And one map was color coded in terms of how far you were if you had a car or a train, and whether you could get there within less than a day or more than a day. And then another map was based on walking. Could you get there in less than a day or more than a day? And the maps themselves, both versions of them, are pretty sobering when you realize how far people are from a hospital. You get spoiled being in Princeton, being in New York. Like I can go across the street. I live next to the hospital I was born in. And it's a good one, right? With lots of research going on. But we have these problems. We've had them for a long time in healthcare, where your economics, your socioeconomic situation, I think, can be correlated to your health and your survival in lots of different indications. And that's a serious ethical issue that we need to fix, right? And I don't think anything in COVID-19 has changed. That not only is that a serious ethical issue that we need to fix, but it's a serious economic issue that the healthcare system and that the life sciences world should want to fix. But then it perhaps unfortunately took those maps going dark for everybody, including people in a big city who live next to an academic medical center, who could no longer get their checkups done and therefore had undiagnosed diseases, who couldn't go manage their chronic conditions actively, and maybe those chronic conditions got worse, or in the absolute worst case, and we are really unfortunately starting to now see the effects of this, I think, have people had to pause therapies and life-threatening conditions, not go in for their chemo because you couldn't go to the clinic to get it, and because everybody there was full of SARS-CoV-2 and you had a compromised immune system. And so if we can fix these problems, not only can we make sure that we keep those maps as light as possible, but maybe we can figure out how to provide healthcare in a more equitable, economically feasible way to the dark parts of those maps. And that's good for humanity. That's what we're all supposed to wake up and try to do. And I feel again, maybe we got the kick in the ass we needed to try to figure those things out finally.
Yeah, and I do think COVID has been an enormous catalyst to things I hear it everywhere, which is, oh yeah, we were starting on that, but we'll get to it. And now we're kind of we need to get to it now.
There was I don't know if anybody took it further, but I remember seeing it was a LinkedIn survey, and it was what's responsible for digital transformation in your company? And it was 3 graphs, the CEO, the CTO, and COVID-19.
Totally. Absolutely. Yeah. I mean, one of the more interesting things that I think Medidata's approach to the more holistic look at data is that when you start to look at the whole thing, and I'm thinking here of the kinds of problems like crime in the New York City subway, and back in the Ed Koch days, they were using, crime statistics to say, hang on, when you have lots of people jumping subway turnstiles, that translates into graffiti. And guess what? That shows an acceptance of low-level crime, and we can start to attack that. More recently, the city controller made a connection between recidivism of kids in city hospitals and mold in their homes. And so they would get the kid in the hospital, they'd fix them up, they'd send them home, they'd be exposed to the exact same conditions, and they'd bounce backwards and forwards. And so the City Hospitals Association actually opened up a group of lawyers who are suing landlords now to remediate mold conditions in kids' homes. So I think there's these kinds of problems that you don't really see unless you see the bigger.
Yeah. And by the way, sometimes these things can, they're socioeconomic issues, but they lead you to learn important scientific things. So you had in New York City, and I don't think the final conclusions are in about any of this stuff. It'll take us a while to really look back at COVID-19 and the data and make sure that hypotheses are confirmed. But one of the things that is, I think, a fact is that if you were in a largely rich, largely white neighborhood and went to the hospitals there, you did better when you had severe COVID-19 than if you were not. and you were in a different demographic and living in a poor neighborhood in New York City. Why? And one of the hypotheses that came out of that was that it actually had to do with how much you were being turned when you were in the hospital, and how much care, like how much physical, which came down to, again, at least the work I was reading, it was related to the percentage of, or the ratio of nurses to patients. So if you were, unless you were coding left on your own and just sitting there in one position, or you had people who were actively coming and moving you around and making sure that, you were either comfortable or at least not laying there without any circulation going to different parts of your bodies or having fluid collect in different parts of your lungs. Again, we'll see what actually happened, but it's actually something interesting medically, right? Is that these advanced COVID patients, not because of necessarily socioeconomic conditions, maybe there are things related to demographics that are legitimately relevant in terms of prognosis, but maybe it was also that we just realized we need to turn people, right? And that's something that then becomes actionable to figure out what to do in a hospital that may not have access to the same amount of nursing staff or the same amount of money. You can create instructions, you can create procedures to compensate for that. So you have to look at all these things and all the data together to generate interesting hypotheses. Obviously, I believe that you need to do the work and make sure that the conclusions that you have about those hypotheses are responsible and correct to the degree that we can make sure that we feel confident in the answer. But the data as a whole is really interesting to look at around this problem of access.
And you've been sort of echoing that theme for a while. In sort of early on, you talk about an experience of falling asleep at the wheel. Yeah. And how that really informed your view of how the attitude we need to take towards due diligence and care and science and, proceeding carefully about things.
No, the incident, I don't want to spoil everything in the book. But no, anytime I am driving and tired, I will either stop and rest, or I will be, my adrenaline will go up because I will think about this time when, I think maybe for half a second, but I was definitely falling asleep or fell asleep while driving. And it's like this touchstone of me driving. Like, why? People are like, why is this relevant to the patient equation? No, it was like that. I was sitting there in Columbia, recording data in my notebook, getting results. And I remember copying them over, and it's it actually was almost as simple, but imagine there's the column, which is plus minus, that was my experimental result. And I was looking at patient records and putting in a plus minus in the next column. And it was, well, how many pluses and minuses was I correct about? And it was I looked at one of my pluses when there was a minus for the patient. I was like, oh, was that really a plus? Maybe that one was kind of a minus. And it was like, wait a minute, you were about to fall asleep at the wheel of academic integrity. You put it down as a plus. It's a plus. Right. And you're not going to look as predictive because you screwed that one up. But maybe it wasn't that I screwed it up personally. Maybe it's that the assay didn't work. And you have to, so I always have that moment. It's oh, wait, no, integrity and experimentation is incredibly important to make sure that we get the right outcomes for everybody. And so that's what that falling asleep at the wheel thing is. Yeah. Hopefully people don't fall asleep at the wheel or be tempted to commit fraud in research. But if you are, you can point to the times that I almost screwed that up and say, oh, I better not do that because Glenn almost didn't slip at the wheel. And you better not do that.
No, we don't.
I don't mean you. I'm pointing to everybody on the call.
No, I agree totally. No, I mean, I think it's just what I like about that metaphor is it's simple. We've all had that experience, most of us. We know it's risky, and we know we shouldn't do that, and yet, I got to get there before XYZ time, or I've got to do this. And so we end up with these risky situations, which if we'd really thought about it harder,
we put ourselves right.
So we had a couple of questions come in about things like AI and what we see going forward. So you've got Dessel behind you now, so you've got a huge resource at your disposal. What do you see as the next couple of chapters?
Yeah, I think, like I said, the first part of of Medidata was really based on connecting professionals who were doing research. Then a decade after that, we really started connecting patients, and really maybe 5-6 years before we were acquired, we started to think about kind of the way we floated on the internet, and then we floated on mobile. Is there something you could float on top of Medidata. And I use Medidata as a metaphor for aggregated data. But the fact of the matter is, like more than half of the research going on around the world was happening and still happens on Medidata. That's a pretty big, like the internet, asset. So shouldn't we be able to put something on top of that? And this idea of kind of breaking apart the silos of data that exist in people's lab notebooks or research projects within a life sciences company, or the life sciences company itself, if it's got its act together to the point where it's sharing data amongst different research programs, which I have to say, I've worked with more life sciences companies than probably almost anybody you can find. And the answer is most don't do that well. And if you can start, and by the way, that's not their job. That's the job of companies like Medidata. And so as we get better at doing that as an industry, the platform providers like Medidata, the life sciences companies themselves, as they can collaborate internally, externally, bigger and bigger circles of data, I think that's when we start to be able to look at those paths that we literally started talking about in more sophisticated ways. And I am definitely not a believer in the idea that you're talking about business models or sometimes the lack of good ones. I feel like a lot of if you fast forwarded the .com era to today, and maybe we're in it again, waving the words business model doesn't mean you should have waving the words machine learning doesn't mean you should have an $8 billion valuation. But that seems to be what's happening. And you can use machine learning to learn nothing. Mm-hmm. Or you can use machine learning with the right data set in the right way, in a fit for purpose expression of new actionable quality information, like in research, information that you can make a life death decision for. You can help people have confidence in from a medical perspective. And having those data sets and having the right algorithms on top of it, that's what I get excited about with machine learning. It's the connection of those two things, the data and the computational techniques, that I think will drive a huge amount of innovation moving forward in terms of helping us look at those paths from a population perspective and helping us look at those paths as individuals.
Yeah, I think it's just incredibly exciting. And I also think, though, that we need to be rethinking some of the, I talk a lot about inflection points and how a business that grows up at any given point in time has these assumptions about what was possible then and what isn't now. And I think when I look at pharma and life sciences more broadly, so many of the knee-jerk reactions are still, we make our money from the pill, or we make our money from the treatment, or we make our money from the whatever it is, the correction to whatever's gone wrong. We're a long way, I think, from thinking about we make our money from, a better population level health outcome that may not require a pill at all. And I think that's just such a different frame of reference that I think it's quite challenging for people in the sector to.
Yeah, I mean, you're much more of an expert about this than I even come close to being. But like these incentive systems that go around those companies and around the individuals who work in them are what's going to help us make that transition.
Yeah,
right.
If we can get it right.
Yeah. But that's what I mean. We have to think about them and try to rethink them to figure out how we do incentivize people to actually to have those better individual and population outcomes. I don't think defining the individual and population outcomes is as much rocket science as people might think it is. I think that's actually where some of the things that we're now doing objectively, quantitatively, that used to be subjective or qualitative. Are you happy? No, I can actually look at you behaviorally, cognitively as a participant in a research study and see how you feel compared to how you felt before. Or that's something that we can do now, but we now need to turn that into business environments that have better outcomes associated with them as well.
Well, and I think one of the other things that I thought was kind of cool about the book is you talk about, patients, we shouldn't be defining what the outcome for patients is. And I'm thinking of someone I spoke to the other day who unfortunately is a young mother, who's got metastatic breast cancer. And we were talking about the experience of that. And my mother had a similar cancer at quite an advanced stage. And it was fascinating to me that this young woman would gladly trade off physical discomfort, not being at her best, not being, who she wanted to be every day, for the chance of more time with her children. Where my mother would have traded off quality of life for whatever time she had left. And I just thought, what an interesting contrast in terms of really understanding what the patient would define as a good outcome.
And it's actually one of the reasons why I don't feel like AI is going to replace the patient-physician relationship, because as much as I love putting a quantitative, objective score on cognition and behavior, it's a one-dimensional score. Even if I'm adding many of them up into a multi-dimensional model, I think the idea that we can have an algorithm decide what the right course is for us, when it may be that elements of quality of life are more important to me than duration, or elements of duration are more important than quality, like that has to be something where we evaluate the possible paths with a partner who has been through that as many times before as physically possible. And just there's many reasons, but that is like one, I think, very clear path, a very clear fact that I think connects us to a future where that patient-physician relationship doesn't go away, even in all these models.
Absolutely, absolutely. I think one of the other things that is really just super interesting is this whole idea of telemedicine in intermediated interventions, where, essentially, so the way I think about it is, there's a lot of stuff you used to have to go to a doctor's office for. So, and I'm sort of thinking of you in your research lab pulling together all these paper files. And I go to my doctor's office and it's like rows of filing cabinets, just full of paper. But the reason that we have that construct is that the equipment was expensive and centralized, right? So you have this blood analyzer and it costs a lot of money and you have to use it across a lot of patients to justify it. Hospitals, same thing, right? If I have a CT scanner, that's expensive. If I have the kind of machine, these could be $100,000 machines. So you have to go to a central place. Whereas what we're starting to see now at the real primary care level is so much of this stuff. And I think it's the combination of software and hardware getting cheaper.
Yep.
We can now have it in our homes. So I can do my own EKG, I can do my own blood prick, I can monitor my own, whatever. And you talk about wearables, right? That data being spread out.
It's the opposite of the problem that we realized in COVID, right? It's if I don't have to I can't go to the doctor to get a new condition diagnosed. Well, maybe I can get that new condition diagnosed, or at least see a signal for it because of the mattress I'm sleeping on. Being able to signal that there might be something wrong from a cardiac perspective. Right. I have to go to my doctor to manage my chronic condition. Well, maybe I can actually do that at home with the right engagement strategy and being on a Zoom or whatever it is with the physician, if that needs to be part of it. And maybe my infusion for a life-threatening illness is something that by combining a molecule with a medical device and the right software, I can actually take it home without having to go to a hospital, which also means in all the dark parts of those map in a non-COVID world, I can get that medicine to somebody in the middle of sub-Saharan Africa where I couldn't get to them today. Right. And that stuff I think is really exciting.
That's really inspiring. Oh my goodness. So I asked for an hour, so I won't go over. But how do people learn more? So what our listeners are very curious. How do they learn more? Find out more.
Book. Flattered if you buy The Patient Equation. It's available on Amazon. You can go to thepatientequation.com. All the proceeds from the book go to Conquer Cancer, the ASCO Foundation. I certainly am not trying to make money off this stuff. And again, it was hopefully a way to share the extraordinary seat that I've had with everybody in terms of finding out more and finding things to go explore. You can follow me on social at Captain Clinical.
Captain Clinical, I love it. And you even have a cape crusader.
It's a fictitious superhero that we came up with years ago. I like Halloween. Tarek likes Halloween. We were Commander Cloud and Captain Clinical. They fight for good science. There's tons of stuff. It's with some Medidata colored glasses, but there's things that are available on Medidata.com, papers about COVID-19 and what happened with clinical research, et cetera. It should be pretty easy to find me.
Great.
I look forward to.
I've enjoyed this incredibly. To be continued, I hope. So let's keep in touch. And if I can be
absolutely
to you guys at Medidata, you're doing wonderful work, and just so thrilled to have been and will to be continued about a part of it.
Excellent. Thank you so much.
Thanks so much, Glenn.
All right, Rita. Thanks, everybody.